And if the blood pressure is high, you repeat it to see what it is, because sometimes, as Dr. Revelo said, you run in for your colonoscopy, you're under a little bit of stress, and you would want to see when you're more relaxed what it comes down to at that time. Better blood pressure control through the HME program was also instituted, and like Mercy, it involved a pharmacist. The pharmacist was clearly involved in it, and the pharmacist sits at the right spot to recognize that your medicines are not yet controlling, you need adjustment in dose or change in medicine at that point in time. And a team member is critically important. The pharmacist turns out to be a well-trained and placed position for that. And I largely attribute some of that success to the involvement of the pharmacists who joined our program at that time. The last program that I'll highlight here by Dr. Hooper was the Healthy Planet program with EPIC. We were felt not to be too small for EPIC, so we started out, but EPIC was very slow to answer our requests for providing information that was helpful. Very useful for billing, and that's what EPIC was pushing itself. That's what the healthcare bought the system for, was for billing codes at that time. But to actually use it to improve patient health or make it easier for clinicians or healthcare providers to provide it, that was on the backside of their priority list at that time. So we've continued to push them to improve. We now have what's called the Healthy Planet program in EPIC, and we have the ability, I can go on EPIC at this point, and I can do slicer dicer and identify individuals who are still hypertension in our specialty clinics, all our clinics, etc., and target those individuals and bring them back, in fact, for further investigation and or treatment at that time. So the ability to detect in population subgroups who are out of control and target them has been very helpful in Healthy Planet program that was used. Secondary prevention in cardiovascular disease, obviously, that often involves medications, statins in people, in addition to healthy lifestyle. Those are important for secondary prevention. Primary prevention does also involve statins in diabetic individuals and those who are high risk, greater than 7.5%. But we do have data that shows here, and I presented it earlier, that there are a lot of groups here shown in green as cost savings that are not normally on statins, that we can show, even though they're low risk, a risk of anywhere from 1 to 4% risk of having a cardiovascular event, that if you put them on a statin, in this case for men, it saves money. What does that mean? It's not cost effective. It's more important, it's cost savings, meaning the reduction in heart attack hospitalizations and stroke hospitalizations more than pays for the cost of putting them on a low-cost statin at that point in time. So we've identified in men and in women additional patients where you save money by putting them on a statin at that time. And if you're hesitant to put them on a statin, you can also get a coronary calcium CT to confirm or not if they do not tolerate the statin. Cost effectiveness shows current recommendations in the U.S. are to treat about 35 million people in the U.S. With statins. But if you look at cost savings, if we add another 11 million people to that who are lower risk, we actually will save about 1,000 to 5,000 events per million people per year with that. And we can save a lot of lives and events and save money at the same time. So this is positive for our healthcare program. For blood pressure, we'll quickly look at current standards. We're under 140. And we have modified those to go under 130. In the SPRINT trial, it looked at a blood pressure targeted at 136 achieved versus 121. The intensive treatment was actually done and was tolerated, including a significant number of people over 75 years of age. It meant treatment with medicine for a large group of individuals to achieve that in pink. So we're treating more individuals, and that is reflected on the hypertension cards you have on your desk for that. What were the results of more intensive blood pressure medicine? Well, you can see right here, there was a reduction in the primary outcome of death, myocardial infarction, or stroke, and it was significant at that point in time. After 1 year, these curves clearly separated. Number needing to treat 61 to save an event in that population. And to summarize it here, here's a table. If we get the more intensive treatment, we save 5 events per year per 1,000 patients. And we say, well, that's not a big number, 5 events. But each of those events was death that was prevented, a heart attack, or a stroke. And those are big for the individual patients if we can prevent them. And the side effect profile was reasonably well tolerated in that population. So lower numbers, if the patient tolerates it, are recommended, and that's why our current number is, if we look at lowering blood pressure from 140 down to about 130, we could potentially save about 40 million lives globally at that point in time. So that is a direction we want to go. And here's our final slide here. Under 130 for both blood pressure and LDL cholesterol for primary prevention. Now, if you have already had a heart attack, we'd further lower the LDL at that point in time. And the current recommendations for stroke and for heart attack would be to get it under 70 at that point in time. Now, with that, that finalizes the UC Davis. I wanted to save time for Jessica. We have on your table hypertension cards we've handed out, as well as cuffs. What we want you to do is now multitask. While you are looking at the questionnaire there, and the questionnaire says, these cards, who should they go to? How do we get them there? And are there any additions or subtractions you want to make before we go to the final printing of 20,000 patients, or 20,000 physicians for that? They're on each of your tables as well as a card. If you can start that now, while you're doing that, you're good at multitasking. I have the opportunity to introduce our next speaker, Jessica, who is going to talk about where we go forward with CDPH at this time. There are a lot of interest at the U.S. Surgeon General's office, the CDC, National Million Hearts, and others nationally, and those have percolated down to California Department of Public Health, and she will show us the way forward, how we're doing, how we can do a much better job. Dr. Nunez de Barria. Jessica.
I just wanted you to show that one slide that showed on the intensive versus the moderate. If we back up 2 slides.
Which one?
The
table?
Forward one. And you show the HF, the actual events that are reduced if you go.
Right,
okay,
yes.
So here, look at the difference between the standard and intensive for heart failure.
Right.
Look at that reduction. So
Yes.
that's the tsunami that's coming at us. That's the biggest, where we see the biggest improvement by the tight control.
So you're correct. Primary events did include heart failure, myocardial infarction, which led to many of the heart failure admissions, but not all. You can get hypertensive cardiomyopathy as well from that. Stroke, cardiovascular death, and heart failure were the events that were reduced, and those events were reduced at 5 per 1,000 patient year at that time. So yeah, no one wants any of these things. You would not check off any of these on the menu if you walked in, whether you want heart failure, whether you want stroke, whether you want heart attack, or whether you want death. So we want to avoid all of those. But anyways, I'm delighted to introduce Jessica, who is now going to tell us about the plans in the future of CDPH. of implementing better healthcare and outcomes for all of our people in California, as well as in Sacramento.
Thank you so much. We're just gonna pull up our slides real quick. I wanted to let the group know that I, like Dr. Balmer, can go through these slides very quickly and very much appreciate the opportunity to be here with you. I want to start though by saying that we have a really unique opportunity to continue in 2020 for a lot of reasons. So let me get through some of the key points so we're all on the same page about the resources at the Department of Public Health. And then I'd like to provide some ideas about moving forward. I'd actually like to suggest some questions to the people who just spoke, because what I'd like to do is take the moment with those of you that are here today to think big, because I know Hattie and all of us in the coming year intend to do much more. I want to also make you aware that we finally have a new director in place at our California Department of Public Health, and we have a new agency secretary. We, and you've heard, have a new Department of Healthcare Services director. We are going as a state through assessment of a master plan for aging that's due October 2020. We are in the midst of the final weeks of a review of how we innovate around Medicaid and the waiver process. So there's a lot going on. And in that, I want to assure you that blood pressure control will be a priority. So let me tell you what else we have gone through illustrious detail today about the importance of ourselves, our communities, and doing more about diabetes, heart disease, and stroke. Now, we've gone through these numbers. You know it's significant. We have some of the authors that were here in putting this together, and we take it seriously. I do want to mention to you, one of the things we want to think about also as a department isn't only when a person has a disease condition, but we're very interested in pre-diabetes as well. The National Diabetes Prevention Program is important because it engages somebody before they have diabetes, and it's recently been proven to work and is now reimbursable. And so be mindful that we're looking upstream as well, and there are so many people at risk for prediabetes. So everything you've said today shouldn't just be for people that are on, many medications. We need to be thinking and promoting even amongst ourselves our best health. Okay, so again, more statistics, and Patty will make these slides available to everyone. But when we, or my group, or I, think about what we do in the Department of Public Health for chronic disease, I think about the adults in the state. I think about how many are impacted, and that, most people don't just have one problem. They have a coupling of problems, and we are getting older, and so let's think about that. Also, let's think about health equity. I know that's important to our director as well. Oftentimes we have resources that only go so far. We've talked about some rural and isolated communities. But just imagine how some communities feel when they're neglected in very large populated areas. We know those isolated hubs of folks live everywhere in our state. So let's be mindful and thoughtful and listen to the community voices. And we're not all going to answer it, but let's try and provide the health system side of it as best we can. So if 27% of the state report they have been diagnosed with high blood pressure, and that was years ago when we had the California Health Interview Survey, we know we have millions in California that can benefit from our care. All right, so one of the things we've received in the recent years is a grant from the Centers for Disease Control and Prevention at the federal level. They have asked us to hone in to improve the health of adults in California in the areas I've just described. And what I want to share with you is that there are 3 objectives they've asked us to think about. Again, the first is to think about how we can identify the patients that you care for who need our targeted assistance. To think about how we can incorporate policies and procedures to do better. And again, part of that system is sharing those policies here in this best practice forum. And finally, how do we continue the team-based care models that you've all been lifting up today? And so I think about its importance here because I live in Sacramento, as does our team. But I also think about it statewide. All these different policy issues that are happening, I'm going to be called in to come up with a substantial plan for blood pressure across the state with the resources and the people we have and the burden of disease we have. And so I want to again talk to you about what I've heard today and think about some ways we can focus and hone in the coming year. I know Hattie's going to be bringing some illustrious national leaders who we expect to hear from us shortly. And so by then my hope is we have a real plan figured out. Okay, so the other thing that the federal government said, mindful of those objectives, was they gave us funding to think about diabetes prevention and management better, category A, and category B, cardiovascular disease prevention. Both are hand in hand for the reasons that you heard today, where those with diabetes are more prone to cardiovascular incidents. So I'm sharing this with you again. These are sound, evidence-based strategies that the Centers for Disease Control has asked us to hone in on. And what you'll be proud and happy to see is that it's all work and space that you're working in as health system partners that are here today, as provider systems here today. We at the Department of Public Health tend to work with local health departments. But we've been asked to go from public health into the clinical setting, and we know that you're up against a lot of new limits, and you've outlined today some of the barriers you're experiencing. So I love the fact that we got to select out of the strategies just a few. So what you'll see is the A1 skipping A2 to A3 was not a mistake. It was just a prioritization in California that we wanted to work with the pharmacists on A3, which you can read there. A4, again, talks about bringing people to National Diabetes Prevention Program. The rest you can read, of course. Again, for diabetes, we want to think about enrolling folks and thinking about bringing community health workers to the team, too, which is very exciting. Category B strategies include, again, cardiovascular disease, everything you've heard about the electronic health record, being able to diagnose people, hone in, again, looking at the care team, B3, before thinking about medication therapy management. We in the Department of Public Health work very hard at looking holistically, so we use the term comprehensive medication management. And I know many of us are working on a statewide committee to think about how to get that happening for our folks. And again, also we want to think about lifestyle change programs for cardiovascular disease. So as you saw earlier, we have varying partners. I'm pleased to work with Dr. Baumer, to work with Dignity Health in Southern California, and many others that have come to the table. Hattie's team has been working with us, and we're pleased with that because she's the linchpin in bringing us all together. So what I want to do is to just, again, this is really outlined in the map you just saw. Moving forward, we intend in the coming year to think about community health workers some more, and other folks for the environment. We will be sharing with you at meetings such as this any resource that we develop. And I want to share with you that we were very successful at the outset of bringing our partners together to talk about some of the resources. These resources are available to anyone interested in being a part of our networks. We have the California Prevent Diabetes Screen Test Act Today group. If you haven't heard of it, we refer to it fondly as PDSTAT, California. We have lots of resources. We have also developed some surveys and have information. We were able to provide stipends to those that needed more help to lift up diabetes self-management education and support programs. We have been, again, as I mentioned, CMM, interested in supporting those interested in the pharmacist on the care team. One of the most exciting updates that I received recently from the work group was that Lori DiMartini, how many of you know Lori Ann DiMartini? She's a lead in one of the pharmacist trade associations here in California. And as a result of many good pharmacist leaders in the state coming together as part of our state work group, she's been able to work very closely with the deans of the School of Pharmacy who have decided that they're going to champion working more closely together as a collective as well. So that is exciting. Trust me when I tell you, deans of competitive schools of any graduate school in California can be difficult, but the fact that they're committed to creating a workforce for us that meets our needs is very exciting, and it couldn't be done without leaders like you. So we also have a pharmacy survey that's going out to see how well-positioned pharmacists throughout the state might be to think about working beyond their current scope in terms of being of assistance. And we truly believe that they're the future, as you've heard today, Dignity Health. The final thing I want to share with you is that we will continue to provide resources. We were very fortunate this past couple of years to receive, it seems small, but to us it's a big deal, funding to do a diabetes awareness and outreach campaign. So in June of 2020, you're going to see some ads, some outreach about getting to national diabetes prevention within the state, specifically targeting certain areas. I would behoove you all to leverage this for your own national diabetes prevention programs in your institutions to support the outreach to let people know that these services exist and are covered. Please join our PDSTAT group if you're interested, because it's via that group that we're going to send information about these opportunities, the outdoor radio and digital ads that will go out. And that means that we can push people to your organization potentially. So stay tuned, more information coming. We're working very hard. It's taken a couple of years to get us to this stage, believe it or not. Also, we had, many of you were at a conference in June. We're very pleased to have that. We are going to be planning a future meeting. I know the new leadership and the path forward, more information to come there. And again, I just want to thank the team that's here in the room that continues to provide trainings. This is how you can get involved. These are the links to be a part of our PDSTAT and our Healthy Hearts California Alliance. Again, these materials will be provided so that you can play a part. I believe this is the final slide I wanted to share with you, but I just have, and I know I blew through that really fast, but we only have 8 minutes because I know we stick to our timeline. This is what I want to share with you very quickly. I've heard some exciting ways that people are getting business done. So my question for Dignity that presented today about being able to get pharmacists on the care team is if you could quickly share with us, and I'm going to tell all the questions so people can quickly answer, because it's like 10-second answers. How did you pay for your pharmacists on the care team? Also, you mentioned that you have the ability to provide information back to the health plans, and I just wanted to know, is that a regular thing? What does that look like? And then finally, Dr. Arevalo, you had mentioned the importance of this group and working with EPIC. And you mentioned many different types of consideration for the care of our patients and our community. You mentioned it would be great to have funding for a new health information exchange. So I want for you to share, is that something we should be honing in on? Is that like the pearl that we should be thinking about? And then finally, Dr. Baumer, you mentioned, and all of us are looking at this card, but my understanding, and Bob Thurman, thank you, in the back, my understanding, these are based on 2017 guidelines. Were we going to update this, or is this the updated version?
That's the updated version.
Okay, all right, thank you. Okay, so back to Dignity to answer, then Dr. Arevalo, and then Dr. Baumer to close it because he has some questions for us.
So about the relationship with payers and our group, we have monthly meetings with a lot of them, and we share information together, and then we form relationships. Did you want to say anything more on that, or did you want to dive deeper on how we communicate?
Well, I guess think of it this way, I'm going to be approached in the coming weeks. How can California, and I want you to take I'm with certain health plans, provider, patient. I just want to think systematically. We have gone through, over the last 2 hours, evidence-based strategies. You guys are doing it. We celebrated the happy song at the beginning. The question is, when the director, and everybody looks at me and says, Jessica, you have just been to Right Care. You've talked with people that are doing it. Million Hearts, all these national leaders are coming to California to say, and what they're going to say is, Jessica, there may be pockets of people doing the right thing. But what is the one or two things you're going to do in 2020 to get us to go across the state? And so in that, is there an opportunity to, instead of going from system to system, to maybe work with the health plans? Is that the better place to go? Is it to go to the providers? Is it the provider? I'm just trying to find out, or is it payment? How did you find the money to pay for the pharmacist?
So let me answer the question of funding. We look at this as an investment. So for our managed care lines of business, it's a way to improve quality, to decrease cost. And as far as the issue of whether this is something that you can leverage to make money, there are codes that our pharmacists can use, but that's not our primary objective right now. We're looking at this really leveraging the accountable care team, offload work away from our physicians and our APP so that they can be much more productive and efficient. It's really the pyramid of care. So it's an investment in our system.
So, and you use it across all your patients, all their health plans, so this is not just, this is beyond your commercial patient population?
Yeah, it's part of our volume to value transition. As we all know, even with Medicare, there's a significant shift into value-based payments with MSSP. We have accountable care arrangements with our health plan partners. So we take the view that all our lives, or our patients we care for, are value-based lives. So we don't really just limit it to the capitated lives.
Great, thank you so much. Dr. Arevalo, the health information
exchange, yeah. Well, I think it is the biggest challenge right now because, as you know, patients move in and out of from one insurance plan to another, from not having insurance to having insurance, and now with our move to try to get as many individuals covered with. I mean, the first issue is coverage, right? And now with Medi-Cal, really focusing on the population that isn't covered, the immigrant population. So the point being is getting the data and really focusing and parsing the data in a way for you to population health. The beauty of